Good evening, sir. Good evening, Sampath, sir.
Good evening. Good evening, Darsh.
Arun is here, and we are just waiting for it to be 8 o'clock, and we'll start right away, sir.
I think Dr. Anupriya will also be joining us shortly, I suppose, sir.
Yeah.
Darshan, I didn't see you in the PDSI, Guwahati. You didn't come?
No, sir. We have to change multiple flights, sir. So that's one thing. Traveling from Manipal, we do not have a good connectivity, sir. That's one drawback.
You are telling me, a fellow who is in Madurai.
Sorry, sir. Yeah. Just about 2 minutes, Jwala. Once it's 8, I'll invite you to start your presentation. Okay. Thank you all for joining in. We are continuing with our ongoing Indian Society of Nephrology Journal Club. And this month, we have with us an interesting article from published in the Clinical JASN. This is from an Australian cohort where they have looked into cases which have been undiagnosed in terms of biopsy or urinalysis, or some of the biochemical investigations couldn't lead them to a diagnosis for the cause of renal failure. In them, they have subjected these patients to undergo genetic testing, and they could find out close to about 25% of cases, undiagnosed cases. They could find a reason for the cause for their kidney disease. So how this article is relevant and what's the methodology used would be discussed by Dr. Jwala. Dr. Jwala is a senior resident from All India Institute, Nagpur. To join with us, we have our subject experts, Dr. Anupriya Kaur. And Dr. Anupriya Kaur is from PGI Chandigarh. She is a clinical genetist. She would talk through us about the different genetic testing, what should be ordered, when to order, and how to interpret, and who should all be a part of the process of the phenotype-genotype correlation, who should all involve along with a nephrologist, would be briefed by Dr. Anupriya. Also with us, we have our senior nephrologist, Dr. Sampath sir from Madurai. Dr. Sampath sir will share his data as well as his inputs on his experience on genetic testing in kidney diseases of unknown etiology. So over to you, Jwala.
Good evening. Today I would like to present for the journal Prep a study on genomic testing in patients with kidney failure of unknown cause, a national Australian study. The study was published in Clinical Journal of American Society of Nephrology in July 2024. Kidney disease, it affects 1 in 10 adults worldwide, and among those with kidney disease, 10% have kidney disease of unknown etiology. Even after thorough workup with serology, imaging, urine analysis, and even after kidney biopsy, about 10% of ESRD patients, a diagnostic odyssey exists in them. And Mendelian forms of CKD, it is found to be positive in 70% of pediatric and 10% of adult cases. Hence, in kidney diseases, genetic cause has a strong relation. But there is high phenotypic variability among patients with kidney diseases. And from previous studies, genetic testing can identify about 10 to 40% of kidney diseases of unknown etiology. More than 600 genes have been identified with monogenic kidney disorders. Among different clinical categories, cystic kidney disease has a high yield with 23 to 49%, giving a positive genetic result, and followed by CKD of unknown etiology. It has around 17.1 to 18.2%, having positive result for genetic analysis. Genetic disease, kidney diseases are often under-recognized. To think, KDIGO recommends us to think genetic. We should consider genetic analysis in patients with young age of onset, especially if they have a nephrotic syndrome, microscopic hematuria, if they have hypertension or electrolyte abnormalities. In patients with strong family history, there can be existence of ADPKD, Alport syndrome, and in patients with young onset of ESRD, and in patients with cystic and anatomic abnormalities, and CKD of unclear etiology, we have to consider genetic analysis. And in patients with extrarenal manifestations like having liver cyst or developmental delay, we have to go for genetic testing. We can use genetic testing as an alternative to kidney biopsy in patients with high risk of bleeding and in patients with CKD of unknown etiology, when the biopsy will at advanced stage will often show advanced disease only and will not be diagnostically yielding. And it can be also used to guide information on immunosuppressive therapy, especially in steroid-resistant or partially responsive nephrotic syndrome. It can be used for giving prognostic information to patients with ADPKD or Alport syndrome, and it can also help in counseling about recurrence in kidney allografts. Coming to different genetic testing methods for patients with CKD, we have Sanger sequencing, which can be done if a patient's disease is known, and specific DNA sequence can be studied with Sanger sequencing. Or we can go for chromosomal microarrays if large number of copy number variations have to be studied. And next comes the targeted gene panel with massive parallel sequencing and whole exome sequencing and genome sequencing. Coming to the genetics testing modalities applicable to this study, the whole genome study, both the coded and non-coded genome is being sequenced and studied. In whole exome sequencing, only the coding portion of the gene is being studied. And targeted next generation sequencing is a pre-curated panel of experimentally validated genes will be targetedly sequenced and analyzed. Whether we have to go for targeted gene panel versus exome sequencing versus genome sequencing is a question often nephrologist has to answer. The targeted gene panels, they have lower diagnostic yielding compared to exome sequencing and genome sequencing. When we do an exome sequencing and genome sequencing, as the number of genes studied is more, the incidence of variants of uncertain significance will be also high. And when we go for genome sequencing, it has an advantage of high sensitivity for several classes of variants, including we can identify deep intronic variations, deletions, duplications, transposable elements, and copy number variants. However, the proportion of exome sequencing negative patients of kidney disease of undetermined etiology, which can be resolved by genome sequencing, is not being systematically investigated. One disadvantage of massively parallel sequencing is it has limited coverage for guanosine and cytosine-rich repetitive and homologous DNA regions. According to the National Kidney Foundation, when genetic testing is recommended, how should we proceed further? If we have to see whether this patient has a suspected family member with the same precise pathogenic variant. If there is a family history and if one disease is being suspected, we can go for a specific variant analysis with Sanger sequencing. But if that is not the case, we have to consider targeted next generation sequencing, where a large multiple disease kidney panel with association, already proven association is studied. But if that comes to be negative, again, the strong suspicion of genetic etiology remains. We have to go for whole exome sequencing or further for whole genome sequencing. But in some diseases like CACWID, where whole exome sequencing or whole genome sequencing can miss the diagnosis, we can go for chromosomal microarrays. And if there is no deletions or microduplications detected in chromosomal microarrays, again, we can go for targeted next generation sequencing or whole exome sequencing or whole genome sequencing. Coming to this study, the aim of the study was to determine the diagnostic utility of whole genome sequencing in a population of kidney disease failure patients in which no other cause has been identified after thorough workup. The methodology is study design was a prospective cohort study. It was done in 18 nephrology units and kidney genetics clinics across Australia. And it was done over August 2018 to July 2022. Due to the COVID pandemic, the study period was prolonged. And the funding fund was given by government only. It was a competitively awarded fund from National Health and Medical Research Council. The eligibility criteria, they included only those patients who did not have any cause for kidney disease after thorough workup, and they should have been at stage 5 CKD less than or equal to 50 years. And if a specific genetic diagnosis was considered, they should have negative genetic test for entry into the study. The exclusion criteria was very strong. They tried to exclude patients who could have a likely diagnosis, like likely or proven diabetic nephropathy, renovascular disease, renal sarcoidosis, primary nephrotic range proteinuria disorder, who could have tuberculosis, paraproteinemia, if there was any exposure to nephrotoxin causing kidney dysfunction, or if there was any findings of obstructive nephropathy, or any nephromegaly, or any family history of cystic diseases, or there was any identified glomerular disease on kidney biopsy, or even isolated congenital anomaly of kidney and urinary tract. These all patients were excluded. So their population for study was highly screened and highly selected. The family history was reviewed in all cases, and those participants with a family history, strong family history for a non-monogenic disease, were excluded from the study. Recruitment was done by patient identification at recruiting sites via service databases in Australian and New Zealand registry, and from genetics clinic, transplant and CKD clinics or dialysis units. And they were identified and matched to eligibility criteria, and after screening for inclusion and exclusion criteria, and they were taken for the study. And The genetic testing modality was like, first the whole genome sequencing was done in all participants, but it was a targeted initial analysis that was done. Analysis of single nucleotide variants and copy number variants was done using a targeted recruited virtual panel of 388 genes with monogenic kidney disease association, which was named as kidneome gene panel. And if after the kidneome analysis with the kidneome gene panel, they whether it was pathogenic or likely pathogenic was classified according to the American College of Medical Genetics and American College of Pathology guidelines. If it was likely pathogenic or only pathogenic variants were considered as positive, whereas benign as well as variants of uncertain significance were considered to be negative result. And if they had a negative result, they underwent a secondary analysis. The secondary analysis was for the analysis of coding regions of all genes using the Mendelian gene panel, and they also did a mitochondrial genome analysis. Variants curated for the Mendelian genome panel was from ClinVar and in silico predications, and for the mitochondrial genome was from genome and mitochondrial pipeline. And the data was recorded in the secure REDCap database. Demographic, clinical, and family history information was obtained, and kidney and extrarenal features were screened for the patients, and family history was thoroughly investigated, including disease among first-degree relatives. From the proposed patients from different nephrology units across Australia, 23 patients did not meet criteria. So finally, 168 were assessed for eligibility, and among them, 148 was accepted for recruitment. And 101 was recruited after genetic counseling and informed consent. And finally, there was a sample size of 100. Coming to the cohort characteristics, the age at CKD stage 5 was around 32 years. Mean age was around 32 years. They had a population with 9 months to 50 years, and 61% were males and 39% were females. And at presentation, at initial presentation, most of them had CKD stage 5D, around 53%. From this diagram, we can understand that adults constituted majority of the patients in this population. Nearly 50% of the participants had a kidney biopsy, and nearly 50% of those who presented with CKD stage 5D, stage 5 had undergone a kidney biopsy. And urine analysis, 68% had some degree of proteinuria, and 17% had nephrotic range proteinuria, and hematuria was present in 15% of the population. And kidney biopsy was done in 54%, more than half of the population. And even in patients who presented with stage 5, kidney biopsy was done in more than half of the population. But even though kidney biopsy was done, most common findings were tubulointerstitial fibrosis and FSGS. And family history of kidney disease, around 48% of the cohort had family history of kidney disease, and among them, 37% of the whole cohort had first-degree family history, first-degree relative having the kidney disease. And prior genetic study was performed in 14. Among them, chromosomal microarray was the most common test performed. Among these 100 participants who were selected after thorough screening, after analysis for single nucleotide variants and copy number variants using initial targeted analysis, 23 had pathogenic and likely pathogenic variants identified. And among the rest 77 who did not have pathogenic or likely pathogenic variants identified, variants of uncertain significance was found in 20. And among the 77 with a negative result after the initial analysis, secondary analysis was done. And after the secondary analysis, two more came to be positive. So this is a prospective cohort study. And the overall diagnostic yield was 25%. Around 20 patients out of 100 patients had a genetic disease diagnosed after a sequential analysis, initial with the targeted analysis followed by Mendelian plus mitochondrial genome analysis. Coming to the results, the most common genetic disease identified was autosomal dominant tubulointerstitial kidney disease, which constituted up to 32%, followed by glomerular diseases 21% and Alport syndrome, and seriopathies and tubular disorders. The most common was autosomal dominant, which made up to 50%, followed by autosomal recessive and X-linked recessive, and one patient had mitochondrial inheritance, which was 14%. Coming to the genes that were identified among the autosomal dominant category, we had UMOD gene, which causes autosomal dominant tubular interstitial kidney disease. Then the collagen 4, A5 and A4 genes, and some glomerular diseases genes and ciliopathy genes, and genes causing CACOD. And in the study, the only cohort characteristic that predicted a positive diagnosis was positive family history, with an odds ratio of 3.29. Comparing the cohort characteristics among positive and negative results, age at stage by CKD did not make a significant difference. The mean age among positive patients were 33 years, and among negative patients were 32 years. And the CKD staging was also similar among positive and negative results. And a family history of kidney disease was significant. Among positive results, 78% had a family history of kidney disease, and among them, among the whole 25 patients with a positive genetic test, 70% had first degree relative with kidney disease. After the study, some new diagnoses, after the genetic study, some new diagnoses were made. The first case is a 46-year-old patient with no family history who had renal cyst in imaging, who came out to be PKHD1 positive, which was diagnosed as autosomal recessive polycystic kidney disease. And another patient had at 33 years, USG showed only bilateral atrophic kidneys, but the renal biopsy showed basement membrane reduplication and atrophy. And this patient, the NPHP4 gene was positive, which was diagnosed as nephronophthisis. So this shows that genetic testing, as we evolve, it helps in expanding the phenotypic spectrum we know about the diseases. They found out that genomic testing sequencing could be considered the next diagnostic tool in patients with kidney failure of unknown cause, and it can be considered before kidney biopsy in patients who are expected to have findings of chronicity and with high risk of bleeding. Now, coming to critical appraisal, was the research question specific? It was a specific question. It addressed a focused issue, that is genetic testing in stage 5 CKD patients of less than or equal to 50 years. And the cohort had a mix of adult and pediatric patients, and this would affect the diagnostic yield, as pediatric patients will have higher yield. Mean age at CKD stage 5 was 32 years in this cohort. This population recruited for the study, it was a very targeted cohort with thorough evaluation for diagnosis, which was done before, but still did not have a diagnosis for CKD. And in some patients, even the previous genetic study was done. And by doing a comprehensive genetic analysis, they attempted to address the question of utility of genetic testing techniques in CKD of unknown etiology. They did a whole genome testing, followed by targeted analysis and secondary analysis. And by this, they ensured that most of the cases were being diagnosed. However, some large copy variants, which may not be detected by NGS, would still remain undiagnosed. For analysis of large copy number variations, chromosomal microarray or NGS, which is better, is a question. Now, expanded phenotype identification shows the utility of the approach in reclassifying kidney disorders, and a complete genetic analysis of all initial targeted analysis. Negative patients ensured a thorough evaluation in the study. A brief about the study. This study was done in Australia in stage 5 CKD patients less than 50 years of age, and whole genome sequencing was performed after genetic counseling, and 25% patients had a positive genetic test, and 80% of diagnoses were of autosomal dominant, X-linked or mitochondrial conditions. And patients with a family history of CKD were more likely to have a positive result. Coming to other studies, one study which was done in Japan which was aimed at identifying genetic diagnosis in adult hemodialysis patients of unknown etiology. They did targeted next generation sequencing, and their panel contained 298 genes associated with CKD. They had a diagnostic. They diagnosed 11.1% patients had genetic disease in their study, and PKD was sporadic. PKD was the most common cause. Coming to another study that was done in France in 52 patients, in which were biopsy-proven patients of CKD of undetermined etiology, and their genetic testing modality was exome sequencing, and in them 40% of the patients had monogenic renal disorders identified by exome sequencing, and in their study collagenopathies was the most common cause for genetic disease. So a pilot study done in United States of America for whole exome sequencing in adults with chronic kidney disease, they found that in their study, 24% of the patients had a positive result. In this study also, around 25% patients had positive genetic testing. Then coming to the applicability of this study in clinical practice, targeted approach. The study has used a targeted approach, and patients undiagnosed after routinely performed tests in nephrology can be considered for genetic testing, and use of clinically accreditable testing was done here. And the funding, regarding the funding, it was not mentioned. Coming to whole exome and genome sequencing in Mendelian disorders, a study was done to see whether the whole genome sequencing or whole exome sequencing is cost effective. They found that whole genome sequencing is the optimal genomic testing choice for maximal diagnosis in Mendelian disorders. However, if we consider small reduction in diagnostic yield, whole exome sequencing can also be yielding. But further information is needed whether whole exome sequencing or whole genome sequencing is applicable. The strengths of the study are strict inclusion and exclusion criteria, and the study excluded patients with clear clinical features of specific conditions such as autosomal dominant polycystic kidney disease, as these are more common genetic conditions and they will affect the diagnostic yield. The limitations are the small sample size, and it had a limited representation of diverse populations, and analysis of US was not done, and broader age group representation was there, and they have not mentioned about the cost analysis. Concluding, genomic sequencing has a diagnostic rate of 25% in patients younger than 50 years with kidney failure of unknown cause despite standard diagnostic evaluation. More studies are needed that include diverse populations worldwide to ensure equitable and generalizable implementation of genetic testing, and to obtain evidence of causality and establish global prevalence and facilitate variant discovery. Thank you.
Thank you, Dr. Jwala. I think it was a very clear and concise presentation. Considering that genetic evaluation is still an evolving field, it has lots of implications for both diagnosis and personalized management. And we have two wonderful panelists, and we would like to hear your views, probably critically analyzing this from an Indian perspective, and also share your clinical experience in this area. Dr. Anupriya ma'am and Dr. Sampath Kumar sir, please. And I request the audience or the members to put your questions in the chat box. We'll be taking that up after the comments from the panelists.
Yeah, thank you, Jwala. This was an excellent explanation of why this study was undertaken and what are the results and how it will impact nephrologists who is managing patients in India. So about the applicability of this in Indian context, we do see a large number of our patients with an undiagnosed chronic kidney disease. So more than 90% of our population, especially less than 50 years, have an undiagnosed disease, which they come with an end-stage renal disease and they are crash landing actually into the dialysis units. So this will really, the cost of the analysis has come down dramatically over the last 10 years, that it is incumbent upon every nephrologist to seriously think of making a genetic diagnosis in a patient whom he thinks that the diagnosis is not obvious. It is not a diagnosis which was made already, like IgA nephropathy, which was a biopsy was made 4 or 5 years ago, and then he has reached the end-stage renal disease. So you have a large number of these, and this will be very useful.
Dr. Anupriya.
Jwala, can you stop sharing your slides? Dr. Anupriya will share her slides and take us through from the genetic.
So I had prepared a short PPT, although I think Jwala has covered everything which I had covered, but but still I'll share it and then I'll share my thoughts also with you. Okay, so give me a minute to share my screen. So is my PPT visible?
No.
Not yet.
Okay.
Yes. If you could just put it onto the presenters. Yeah, it's perfect.
Yeah. So since I've prepared this PPT, Darshan and everyone else, I'll just quickly go through it. So like Jwala has shown that one has to think genetic, and you all very well know all these indications for genetic testing. And I think the strength of this study was a very, very stringent inclusion and exclusion criteria. So that is applicable across all the other specialties in which we do the genetic testing. That more strict you are with your phenotype, and more evidence you have of that it is a genetic disorder, and if you can point out what genetic disorder, that helps us in our analysis downstream. So many a times people think it's a genetic test and it should pick up if there is a genetic problem. So genetic testing is like you have to find out a single variation among so many variations which come out, and getting a good phenotypic input from the clinicians is very important. So the question is that what should we do when we are suspecting a clear-cut monogenic disorder, or if we are facing a disorder in which we don't exactly know what should be the etiology. So as discussed, that these are the battery of tests that are available, and just to give you an idea that actually out of 19,000 or so genes which are coding for the proteins, we are at the moment we are just knowing around 6,000, 7,000 of them to be clearly associated with some phenotype. So we don't know what are the roles or what are the disease phenotypes of many other genes. And out of that, the genes which should be of most interest to you will be somewhere in the range of 400, as different studies are showing 400 to 600 genes only. Now, this is clear, I think, to everyone that when we do a Sanger sequencing, we are looking at a very small stretch of DNA, base by base, whereas when we do a next generation sequencing, it is a high throughput sequencing. So I understand that you will not be ordering Sanger sequencing in most of the cases unless you have a known variant in a family. So there is a family history, and the patient has come to you with a report that the father or the uncle or anyone has already undergone a genetic testing, and this is the diagnosis, genetic diagnosis. Then you need not order the whole NGS. You just need to order a Sanger to confirm the disease in the patient that you are seeing. So, I mean, so this is the comparison that um, I hope everyone is knowing the difference between all these panels and all, and the exomes and the genomes. So the issue is that we increase our coverage, but we also increase the number of VUSs, and slightly go down on our accuracy because the depth is less when we go towards genome sequencing. Uh, but I think whole exome or a targeted whole exome is the choice. So one should understand that in today's time, it's a two-edged sword. So the interpretation of the results is actually the critical step. So I can understand when you get these reports with VUSs, you are in a fix as to how to go about it. But on the other hand, if we start doing whole genome sequencing on a clinical basis, there'll be a lot of data storage challenges and validation challenges. So when you get a VUS, I think this is the core um problem that uh, clinicians they are facing is that so the commercial labs they are releasing these reports with the VUSs. Now you should understand that these labs are getting as I said, the more phenotypic information you give, the better analysis will be done. So it's very important as a clinician to understand that you have to add on everything that you have done in the workup of your patient till you have thought that no, I think it is a genetic disorder and I therefore want to offer a genetic test in this person or in this family. So you have to give all those phenotypic terms to the lab or the data analyst in order to help them to, pick that needle out of that um, big hay. So first thing is that so you have to give the clinical context. Often, when we find a VUS, a segregation analysis, that is, we try to find out is the variant present in the biological parents of the proband, and are the parents affected or not? So that in some ways, so for a recessive disorder, if you are getting two variants and the two variants they are found in trans, that is one variant is coming from the father, one from the mother, then that adds on to the criteria for pathogenicity. So segregation analysis helps. On the other hand, if it's a dominant disorder and you are finding the same mutation or the variation in one of the parents, and the parent is now considering, you have to consider the disease, the genes penetrance, the variable expressivity. So for cystic kidney diseases, you will have to think that has the parent crossed the age where the cyst should have appeared had he been affected by this variant or not. So all these considerations have to be there. And then you need to consider that, okay, if the parent is carrying it, then probably it's a benign variant and it's not disease causing in my proband. So segregation helps a lot. Often what people in the West are doing are that they are doing trios. That is, they will sequence the parents' DNA if available. So since I'm a pediatrician, I mean the probands that I deal with, usually the parents are alive. I'm not sure of the adult scenario, but if the parental DNA is available, the trio testing actually helps us a lot. when we are filtering out the variants which seem to be unrelated to our phenotype. Then population database is very, very important. And actually, this is where I think we are lacking, because whatever population databases are there, like the Nomad and the Exact, etc., the contribution of the Asian population. So at most, they are going to tell that these many individuals were from Asia. Now, in Asia, also South Asia, East Asia, it's a very broad group. So people have found that there is a utility of measuring it in your own population. Many a times, the big labs, they do this with the help of their own internal databases also. So if the variation that you are seeing in your patient, it is there in the population, then it's unlikely that, so these population databases consist of individuals who are otherwise healthy. So it's very unlikely that it would be disease causing if it is present in the population. Conversely, the rarer the variant is in a population database, it gives a little bit of supporting evidence to the pathogenicity. That had it been disease causing, then because it was disease causing, it's not there in the population. So often we have to take help of the population databases as well as the disease databases like the ClinVar. So these database in the disease databases, there various commercial labs or academic institutes, they are submitting their variants and the classification of their variants to this database. So if you find that someone else has also seen the same variant with the same phenotype, then that also adds on to the criteria. So why am I again and again referring is that there are strict guidelines, criterias laid, which we call as the ACMG, AMP, which Jwala also mentioned, and we need to strictly adhere to these criterias and then consider the variant whether it is crossing the scores which are meant for pathogenicity and likely pathogenic scores. So going into the depth of all these criteria is not possible. But then, also I like to tell that now these criteria have become so refined that they have the ClinGen, which is you can say a group which is trying to refine these criteria which were given by ACMG. It has formed clinical domains working groups. So there are VSEPs or variant curation experts, expert panels who will only be the experts for cystic kidney diseases or celiopathy genes. So sometimes there is a deviation from the general ACMG criteria to the ClinGen specific clinical domain, kidney domain working VSEPs. So one has to very, very carefully see before calling a variant as pathogenic or likely pathogenic. And it's very, very clear in everywhere it is said that you should not take any clinical decision based upon a variant of uncertain significance. So, but one has to understand that variant classification is dynamic. So, many a times when I say this term, I think um, many of you might feel that how can it be dynamic? I mean, at this point, if you have done everything to find out, so it's not like that. Because as I said, first of all, that a number of genes we still don't know what these genes are causing. And for example, I think why they have done a very smart way of doing a whole genome. But then in this study, they have restricted their analysis to only the kidney genes. So they have cut down on their hard work on data analysis. They must have cut down on their VUSs also. On the other hand, they have kept the sequencing of those 100 individuals in their storages so that the same data can be looked again if some new gene has come into the literature, so they can see again those patients which have been left undiagnosed. So um, so I think that is what I wanted to contribute in this session. And I think for all the DM residents, this was, even for me, it was a very good read, giving very clear guidelines and examples as to what genetic testing to be done. Thank you.
We would
Thank
request
you.
Dr. Anupriya
Yeah.
to be on the thing so that she can answer some of the questions also. Sampath sir, your thoughts. After that, we'll take up
Yes.
the chat box.
So the issue of the ethnicity comes in this study because we don't have data on these 100 individuals. How are they ethnically diverse? Do you have any data on that in the supplementary material, Jwala?
No, sir, they have not
They are not.
brought about
It
the
is not available.
special phenotype.
Okay. So there are a couple of things which we most often discuss about, couple of diseases which are not finding the place in this analysis. One is about the atypical hemolytic uremic syndrome, which almost all of us seem to be seeing a ghost in every corner. That there has not been even a single case report or diagnosis made in this analysis. Am I right? There was no atypical HUS has not been made. So that is again open for discussion as whether the population that they have taken up in Australia, whether the incidence of atypical HUS leading on to chronic kidney disease is so low that the diagnosis, or the other aspect is whether the diagnosis has already been made without a genetic testing in these patients, and so they did not include these patients. Your thoughts on that?
It's the second one, sir. The diagnosis is already made. They do,
Possibly.
because having worked in that system, what I've seen that is they do get a genetic test for those patients, but they have not included in this cohort because this is only for patients who do not have a etiological diagnosis. Since there is a etiological diagnosis of TMA, and they would have done TMA has caused end-stage kidney disease. The cause for TMA, whether it was an antibody mediated or whether it was a mutation mediated, then they would have classified as different. These are unknown causes of end-stage kidney disease.
And end-stage renal disease with calculi also been excluded. I am not able to see that information because we do have large number of our patients reaching end-stage renal disease with calculi. Darshan, do you have any data on?
Usually, what I have seen there is the turnaround time is very long there. So, for example, primary hyperoxaluria. If you are indicating primary hyperoxaluria, biochemical tests and these things would come early by the time their genetic test turnaround time is. So probably there is already a diagnosis through biochemical as well as radiological and background history that they are not a part of these cohort.
Possibly. So
because
these two,
they have specifically mentioned, sir, that CKD with no other recognizable cause have only been included. So I think that is the reason stone disease would have made it a recognizable. Also for
so what I will do is I will just share my experience in my unit. Can I share? Okay, let me see.
Most of the times, what I've seen there is almost whenever they suspect, they all do get the genetic test because it's done for free through the Medicare, sir, in Australia. And most of them do consent, and definitely they have.
They do WAS for everyone, exome sequencing, sir, or
No, their insurance policy asks them to go for panels first. They have panels for all diseases. For example, if you're talking about alternate complement pathway, they have a panel for that. If you're talking about hypertension, young onset hypertension, they have a panel for that. So their insurance policy guides them to go for panels than exome sequencing. But that said, they have enough. They have the population is hardly in Sydney, where the population is hardly 26 million. So it's easier. Not many cases would be there for them. Okay, if the panel is negative, then they'll go for exome sequencing. So one is fund is not a problem. Number of samples is there's not much of samples where they are short of time. So all these things makes them based on the insurance coverage, they first order panels and then they go for exome.
Is my screen visible?
Yes, sir.
yes, sir.
Okay. So we had our share of around 46 samples we have sent for patients who had unclear etiology of renal disease, combination of both glomerular disease as well as chronic kidney disease over the last 2022 and 23. So I digged out all these statistics. So we had 4 out of the 34 patients who had CKD of unclear etiology. We were able to get 4 cases of GRHPR mutation of hereditary hyperoxaluria type 2. So a bit unusual that in type 1 is very commonly discussed, but we do have large number of patients with type 2. So we had 4 of them, and one of them had undergone a kidney transplant and a liver transplant and doing well. So we also had 3 cases of Alports. So X-linked was only 1, and we do have the autosomal dominant variety of the A3 in 2 cases. Then large number of pediatric chronic kidney disease in the first and second decade had this nephronophthisis complex, the ankyrin, NPHP1, etc. And there was one patient who had this NPHS2 mutation. We also had patients with HNF1 beta, 2 cases, who had both the diabetes and cysts in the kidneys. And we had one with type 1 hyperoxaluria. And KCNJ1, we had this Barthé syndrome type 2 end-stage renal disease and C3 factor deficiency and deletion in one patient. So we had large number of negative studies also. And when I had sent, expecting that it will turn out to be positive, I was left red-faced, because these were the patients who had typical hyperuricemia and renal cyst. I was expecting to find autosomal dominant tubular interstitial disease, but unfortunately, I have not been able to get that. Possibly, the answer may be that the homologous regions are more, and diagnosis may be uncertain in MUC1 and other genes. So you also have steroid-resistant nephrotic syndrome. Ultimately, I am sure almost all these children will land up in ESRD, and most of them were variants of uncertain significance, INF2, ANLIN, PMM2, AVIL, NUP85. So all these immediately led me to updating my knowledge about the huge number of proteins in the glomerular basement membrane as well as in the podocytes. So my conclusion is that in my studies, 44% of cases of CKD of unclear etiology, be it with stones or even with stones, as Darshan was telling us, the diagnosis of hyperoxaluria is made with biochemical means in our country. So this is very difficult. So we are resorting to genetic diagnosis. VUS were very common, likely pathogenic and pathogenic are less common. And CKD in in the first 2 decades, mostly it is nephronophthisis complex. Genetic testing is becoming more and more affordable now, and diagnostic workup should include it, especially when you are thinking in terms of transplantation. The other question that I would have for the others is about the reason as to why many of our patients have only one pathogenic variant in the gene and the other variant is not available, and so it is all left, we are left guessing whether in our country, because of the glomerular endowment, even if one heterozygous mutation is available, because of the second hit of low glomerular number, are we seeing more of these patients reaching end-stage renal disease, chronic kidney disease? This is a thought that I had when I screened through my data. Maybe Arun Kumar and Darshan may have an answer to this.
I'll probably leave
I'll
it to
stop
Dr.
sharing.
Anupri.
Yeah.
Thank you. Dr.
Yeah.
Anupri, I think you got the question from Sampath sir. We have any explanations for that? We do not have more of homozygous variants. We have a
Yeah, so speaking with on genetic terms, sometimes so these NGS technologies they miss out larger deletions. So sometimes what happens is that on the other allele there is a large deletion which is not picked up by NGS. So in case you are suspecting very clearly that it is a recessive disorder and I'm getting only one variant, and the other variant is probably missed, then we try to look in within the genes, some exonic deletions are there. So MLPA is a test for that. Or sometimes if there are large deletions, then one might have to go for a chromosomal microarray or some other. So that is one reason which you should consider if you have a very strong suspicion of a recessive disorder and the variant that the lab has reported is a clearly pathogenic variant matching the gene of your interest. Regarding the second hit idea, what I remember, I'm not a nephrologist, is that for cystic kidneys, probably such type of mechanism is known. But as far as, let's say, for nephronophthisis or for Alport's or for other disorders, these are germline disorders. So if there is a mutation, it should have been picked up in the DNA coming from the peripheral blood. Sometimes it happens that with the mitochondrial disorders, you might have to you might not be getting the variant in the peripheral blood DNA, and then you might have to do a biopsy, and the tissue per se will undergo the gene sequencing, and that might pick up because in mitochondria there is this problem of homoplasmy and heteroplasmy. So the organ which is affected is supposed to have the maximum number of mutated mitochondria. So at present, I remember these two conditions, probably cystic kidney diseases and mitochondrial disorders, in which you might have to per se do a renal biopsy and test on that for a missing mutation.
Yeah. See, the other issue is about the widespread clinical diagnosis that we always say for Alport syndrome, about the lenticonus and keratoconus, and also the testing of hearing loss and everything. many of these patients whom we have diagnosed, none of them had any abnormalities in the eye or in the audiometry. So again, clinical diagnosis stops at some time, and beyond that, it is better that when you are not sure, go for genetic testing if you are highly suspicious of a disease causing variant. And especially in the context of very, very low cost of these analysis now in India, you have to latch on to a good lab, which gives you a good explanation as to why it is VUS or why is it pathogenic, why they have to do their homework. And then if they give you a good readout, then you should go ahead and then continue to give your samples to that lab alone, because labs are aplenty. They are cropping up everywhere. So it is better that you have a dedicated fellow who will be answering to all your clinical and genetic queries, and then you build up a rapport with him. Thank you, Darshan and Arun.
We have another 4 minutes to go. So we'll take a couple of questions.
Yeah.
Can you just screen the questions in the chat box? On the same breath, sir, I'll just have two comments on the cases. You were mentioning about Alports. So this is what I had to experience because I run a pediatric nephrology program also here. So what happens is most of the steroid-resistant nephrotic syndromes, in my cohort, what we have seen is, especially if there is no family history or if there are no extrarenal manifestations, the pickup rate is 10%. I think the similar percentage is also there from SGPGI, where the NPHS1, NPHS2 are very rare in Indian cohort. So what often I do is I do not subject them to a genetic testing immediately, because once I start them on CNIs, I need to do a biopsy 2 years down the lane to look at whether there is a CNI toxicity. So often what I do is I do a genetic testing at 2 year I do a biopsy at a 2 year mark to see whether it's an FHS or what kind of a thing. And then if there is something odd, then we go for the genetic testing. But what happened, there was a family with me, 8-year-old girl came with me. She was not, she had hypertension, she has microscopic hematuria, and she was not responding to steroids. Then we did a biopsy, it came as IgM nephropathy. And yes, we started the same CNIs and as a treatment for SRNS kind of a thing. 2 years, and since she was a girl, we didn't screen much for that, and she didn't have obvious hearing loss or lenticonus was, visual disturbance was not there. 2 years later, brother also presented with the similar manifestations of nephrotic syndrome and this thing. And that time, since she was IgM nephropathy, did a biopsy on this girl, this boy, and it was also IgM nephropathy. And incidentally, why is this IgM nephropathy coming in family? So we did the genetic analysis at that time, then came up to be the autosomal dominant Alports in the genetic. And then we had to, it helped us in managing, because we stopped all the immunosuppressions for both the family. So yes, things are a little bit tricky, probably because it's not easy. Even though it's about 18,000 now, or somewhere around 16, 17,000, still a group of patients would not go for it directly. That's what. Yes, sir. Yeah, Arun, any questions from the chat box?
I think most of the questions I think we have answered, sir. One question from Dr. Anand was about, is there a policy for mandatory reporting of the actionable genes, even if unrelated to kidney diseases, while doing a whole genome sequencing in India? I think some of the international guidelines do have it. To my knowledge, there is no national guideline for the same. Dr. Anupriya, ma'am, please.
Yeah, so there are guidelines as to the genes and the variants or the secondary findings. So by and large, what I grossly remember is some 80 or 100 genes list is there by the ACMG, not specifically for our country. Most of them have genes which are linked to cardiac disorders and arrhythmias, cardiovascular phenotypes, or they are cancer, hereditary cancer genes, or metabolic error genes. So, not for some kidney diseases. So, medically actionable gene list is there, but I am not sure whether any diseases related to the kidneys are there or not. Largely, these genes are of the cancer genes and the cardiovascular phenotypes or the metabolic errors.
Dr.
Okay.
Vivek?
I think most of the other questions you have already dealt with. One question was about whether all CKD use should undergo a genetic diagnosis, because CKDU has become a very favorite diagnosis of many people. Even without a classical CKDU, we do call it like that. So should all CKDUs have a genetic testing done? So I just want to open this up.
Yeah, because CKDU, the group of patients whom the Australian cohort they have tested almost looks like a CKDU. So all of them had most of them had very minimal proteinuria, and then tubular interstitial disease. Biopsy had shown only fibrosis. Typically, this is what is seen. So it is very difficult to tease out the environmental toxicity versus genetic in these patients. I think individualization is important.
And I think our understanding is still limited. I think till we have variants of significance, our opinions are going to differ. Probably our understanding, we need a dynamic process of learning and unlearning about genetic diagnosis per se. So any final points before we wrap up this, JC?
So from my point of view, it was a real eye-opener because I was able to get my data out and then look at how in which group of patients I have sent for genetic analysis in CKD. So I should thank the ISN for this great opportunity. Thank you.
Thank you, sir. Thank you,
Thank
Dr.
you.
Anupriya, for joining in, and thank you, Dr. Jwala, for a wonderful presentation. We'll see you all next month for our next session of JC. Thank you all.
Thank you.
Yeah, thank you all. Thank you.
Thank you. Thank you.